it's a pleasure to have you joining us for what promises to be an insightful and clinically valuable discussion for those that actually stuck around. We appreciate you. Tonight, we're focusing on the evolving role of endomyocardial biopsy in contemporary cardiac care, particularly in its utility in the evaluation of transplant patients and individuals with unexplained or complex heart failure. We're fortunate this evening to be joined by two distinguished experts from NYU Langone Health System, Dr. Michael DiVita and Dr. Tony Saroan. Both of them will bring deep clinical expertise in their experience in myocardial pathology, advanced heart failure, and transplant cardiology, if not in tech and internet use. But that's on us. They're going to be sharing their perspectives on when and how they utilize endomyocardial biopsy in their practice, as well as discussing emerging trends, clinical indications, and procedural nuances. Before we begin, just a quick reminder, the chat function will remain open throughout the event. If you have any questions, please type them in the chat box, and we'll be monitoring it, and we'll be trying to address them and get to them as many as possible before the end of the presentation. Without further ado, it's my pleasure to introduce our first panelist. I'm pleased to introduce you to Dr. Michael DiVita, a heart failure and transplant cardiologist at NYU Langone with over 15 years of experience in managing advanced heart failure. His expertise spanned interventional approaches, including coronary angioplasty, percutaneous support, and remote monitoring strategies for optimizing hemodynamics and improving patient function. Dr. DiVita is also deeply committed to patient-centered care, ensuring shared decision-making through education and clear communication. Welcome, Dr. DiVita. We're going to turn it over to you.
Thanks, Pete. Thanks so much for that nice introduction, and thank you to everyone who stuck around to hear this presentation. Excited to talk to you guys, a little bit about endomyocardial biopsy and how we use it. We can get the slides up here. Do you want me to just share the slides? All right, go to the next slide. Beautiful. All right. Very good. So, yeah, quickly, I have no disclosures. So I'm going to start off this this meeting talking about some of the guidelines and some of the indications for endomyocardial biopsy. As we'll talk about in a minute, I definitely think it's an underutilized diagnostic tool for us. It's got a lot of good clinical indications, can get us some really high yield information. So we're going to talk about the different scenarios and guidelines for when we should use endomyocardial biopsy, discuss some of the downfalls of when it may not be as useful, and some of the differences in diagnostic yield depending on the disease that you're looking for and the pathology, and then sort of talk about where this field is going and other ways that we can use endomyocardial biopsy in the future. We can move to the next slide, please. So I'm sure many of you know what an endomyocardial biopsy is, but just as a quick refresher, it's a way of us retrieving myocardial tissue directly from the heart muscle itself that we can look at under a microscope and many times perform, additional testing with different stains and different chemicals to highlight different pathologies, different diseases. In general, it's generally performed from the internal jugular vein. Some other centers will approach it from the femoral vein. But these are really the two most commonly used access sites for biopsy procedures. Again, most people will obtain the samples from the right ventricular side of the endomyocardium. There are some indications for left ventricular biopsies. We'll talk about those a little bit later. And then, it's really important to use this diagnostic tool in the correct settings. And you kind of have to understand which are the correct patients, which are the appropriate patients and the appropriate settings to use that for. And as I said before, it's definitely probably underutilized and an important tool in our diagnostic toolbox. Next slide. So many years ago, back in 2007, there actually a group of cardiology societies came together, the ACC, the AHA, the ESC. They came together and they came up with set of guidelines to figure out who should really get endomyocardial biopsies and which settings is this most useful. And you can see here, they actually came up with 14 different scenarios where they thought that endomyocardial biopsy was useful. They obviously graded them, class 1, class 2, class 3 recommendations. But talking more in general terms, the individuals who benefit most from an endomyocardial biopsy are ones where they have some sort of cardiomyopathy or myocarditis that is of uncertain etiology. Obviously, a big utilization of endomyocardial biopsies in our post-cardiac transplant patients, and we do a lot of that here in New York, and we can talk about that more. And then there's a select set of diseases that are infiltrative or storage diseases where this diagnostic tool is very useful as well. And so we'll talk about each of these in a little more detail on the next slides. So breaking it down into different classes of recommendations, looking at your class 1 recommendations, the patients who benefit most from having an endomyocardial biopsy are your patients who come in with fulminant heart failure, usually less than 2 weeks duration, and they are really sick, really in rapidly progressive heart failure. Usually these patients are admitted to an ICU, they're on multiple drips, they may be on mechanical support devices. They're really having rapid progression, rapid failure of their heart function. These are patients where, because of select disease processes, it's very useful to identify what is causing it quickly so that you can identify it. The number one sort of disease that we think about right away when you see a patient with fulminant heart failure like this is giant cell myocarditis. But there's other forms of myocarditis as well where they will progress very rapidly, and you want to make a rapid diagnosis. Other scenarios are ones that are not quite as fulminant, but also kind of rapidly progressing, and those are ones where you do have a dilated LV, you have ongoing ventricular arrhythmias or some sort of electrical disturbance with an AV conduction block that are not really improving with your best attempts at managing them medically. And so these patients may not fall into that less than 2 week category, but they may sort of have their disease going on for somewhere between 2 weeks and 3 months. And again, not really responding to your therapies, and you need some more information to try to understand why they are, sick and remaining sick. So these are the people that we consider for class 1 recommendation for biopsy. Your class 2A patients are, in some ways almost as sick, obviously not quite as sick as your class 1s. The ones in this category that I really like to focus on and really think about are the ones who have a restrictive cardiomyopathy and a more likely infiltrative cardiomyopathy. So the ones that fall into this category are your ones for amyloidosis, suspected anthracycline toxicity, and other sort of restrictive cardiomyopathies that you can't quite make the diagnosis for. There is some indication for these in this class as well for cardiac masses, intracardiac masses, with the exception of myxomas. The reason we tend to stay away from myxomas is that they tend to be very friable. And when you try to biopsy them, you can sort of break off little pieces that can embolize either, as a stroke to the brain, or if you're on the right side, into the lungs as a PE. So, if there's thought that it could be a myxoma, usually recommended to stay away from these, but any other cardiac masses, cardiac tumors, there's a class 2 indication to try to biopsy them percutaneously and get a diagnosis before determining their next steps in therapy. And then again, sort of related to the first group in the class 1s, your patients who have this more indolent, long-standing dilated cardiomyopathy, who again are not really responding to therapy with or without ventricular arrhythmias. These patients can also undergo endomyocardial biopsy for further evaluation. Next slide. And then lastly, anyone else that you sort of feel has indicated that you're having trouble making diagnoses. So if you have someone with unexplained hypertrophic cardiomyopathy, and we tend to see this a lot where patients will get referred to our hypertrophic specialist for evaluation for HCM, and it's not quite clearly HCM, and maybe there's some thought that there could be some infiltrative disease process going on. These are patients where you might want to think about doing a biopsy to further identify what is the underlying pathology. Patients with unexplained arrhythmogenic right ventricular cardiomyopathy or other unexplained ventricular arrhythmias are other patients that you can think about biopsying them. Again, the indication not quite as strong, but if you need to make the diagnosis, if you're not quite sure, what is the underlying etiology here, then endomyocardial biopsy is a very useful tool to try to make that diagnosis. Next slide. Then, of course, as I mentioned before, endomyocardial biopsy and heart transplant is still the gold standard for us to try to detect acute rejection, either cellular or humoral. There's two different types of rejection that we see in patients with solid organ transplant. The ISHLT, which is sort of the governing body for heart and lung transplants, developed this grading system based on the pathologic findings that we see when we do the endomyocardial biopsy and look at the specimens under a microscope. And that sort of guides us in how we, grade the rejection, how we treat the rejection. I will say that this is, while it's still the gold standard, there are some newer non-invasive, non-endomyocardial biopsy tests that are coming out, blood tests and other sort of gene expression tests that are not quite taking over for endomyocardial biopsy, but are sort of adding to our regimen and our testing abilities to try to help to identify rejection either, more intensely or, more rapidly than having patients come in for endomyocardial biopsy. So while there may be some centers who are using the blood test as a alternative to endomyocardial biopsy, I think in our space, in our institution, we use it in some ways it's a complement or supplemental testing modality in addition to the endomyocardial biopsy. So this is still our gold standard at our institution. We still use it very frequently for our transplant patients. And so these are, a variety of the different pathologies that you can see after you obtain your endomyocardial specimens. You look at them under the microscope. So if you look here in the top left corner, you see, what is the diagnosis of a lymphocytic myocarditis, where you see all of these lymphocytes, those little purple dots that are scattered out amongst the myocardium, the myocytes. And those are your lymphocytes that are invading the myocardial tissue and causing the inflammatory response and causing the heart failure and systolic dysfunction, and sort of highlights with additional stainings that you see in panel B. And then, moving next to it is cardiac sarcoidosis to the right of it. Again, you can sort of see these granulomas infiltrating into the myocardium and causing disarray of the myocytes and disarray of the myocardial architecture, obviously leading to, the inefficient myocardial function. Moving down to the bottom left, you see eosinophilic myocarditis. Again, you sort of see those purple dots scattered amongst the different myocyte cells, sort of leading to a separation of them, and that eventually leads to the inefficient contractility of the heart. And again, highlighting with the immunohistochemical stains in that panel D there, you sort of see them scattered out in all those greenish brownish dots. And then lastly, in the bottom right is amyloidosis. And if you use special staining, the Congo red staining, you see those, brown specks, those brown highlight there, which are your amyloidosis depositions inside of the myocardium. So, again, a variety of different pathologies that you can pick up with the endomyocardial biopsy and the specimens. And I think actually, if you go to the next slide, there's even a couple more examples. So these are some more sort of less common diagnoses, but things to always think about if you have patients with unexplained cardiomyopathy. One of them is hydroxychloroquine myocarditis. So patients with rheumatologic disorders who have been on hydroxychloroquine for a long time. This can actually cause a specific myocarditis, where you see in the basic H&E stain on panel A, you see that you get these sarcoplasmic vacuolizations, and those are sort of the bigger white-looking cells interspersed there. And then if you actually look at it under the electron microscopy, I don't quite know how to describe this from a pathologic standpoint, but what you're looking at there is what's called Lewy bodies. And those are sort of hallmark signs for hydroxychloroquine myocarditis. Again, if you look over to the right hand side, you see with those big white arrows pointing to these big giant cells. And this is what you would see if you had giant cell myocarditis. And then lastly, at the bottom of the slide, there's what, a really fulminant acute cellular rejection heart transplant would look like, where you see all of those little purple dots scattered around and the myocytes really not interacting with each other, really having all of those T cells and lymphocytes scattered in between the myocyte cells there, causing a lot of disarray and a lot of havoc on the ability of the heart to function well. So again, just between those two slides, you can sort of see all the variety of different etiologies and different disease processes that we can identify by doing the endomyocardial biopsy. And so that's why it's really such an important diagnostic tool. Next slide. But one thing that you always have to consider when you're doing this is that there is different diagnostic yield for these different diseases. And so some of them have a much higher diagnostic yield than others. So for instance, things like amyloidosis, myocarditis in general tend to have a little bit higher yield because of the fact that they tend to be more homogeneous processes. They tend to be sort of involving the entire myocardium, unlike things like sarcoidosis, which tends to be sort of more isolated to specific parts of the myocardium. And if you don't happen to biopsy those specific parts where that disease is affecting the myocardium, you're very likely to miss the diagnosis and sort of get a false negative result from your endomyocardial biopsy. So one thing that's always important to think about before you proceed to the endomyocardial biopsy is to think about diagnostic imaging prior to performing your biopsy to really sort of understand what is your likelihood of obtaining an accurate and diagnostic sample versus other processes where, again, the disease may be affecting only part of the myocardium and your yield may be a little bit lower. So always think about doing diagnostic imaging tests before you move straight to the biopsy. And this actually here on the right side was a study that was done, single center study by a group here in the US, where they actually went back retrospectively and looked at their biopsy samples based on what the presumed diagnosis was from their diagnostic imaging. And you can see here in this first set of bars where they looked at myocarditis, their diagnostic imaging had said, yes, this is myocarditis. They went ahead, they did the biopsy. And in just a little more than 50% of the cases, the biopsies actually came back positive for myocarditis. Almost half of them came back negative for myocarditis. And so that always begs the question of, was the diagnostic imaging wrong, or was the yield of the biopsy just not sufficient because maybe there was some isolated segments of the myocardium that were affected more than others by the myocarditis, and the biopsy samples were not obtained from those areas of the myocardium. Now, if you look at amyloidosis, you see that there's basically like a 2-to-1 fold yield in amyloid, so kind of a better ratio, kind of a better percentage. And again, that's because amyloidosis tends to be more of a homogeneous process. It tends to affect the entire myocardium. And so your chances of obtaining a sample that has amyloid in it are much higher because of that fact. And then again, just looking at sort of tumors and dilated cardiomyopathies, these yields may not be as good either. So you really have to think about the process that you're suspecting and whether or not endomyocardial biopsy is going to get you the ideal diagnosis. Next slide. And then again, this was just another study out of France, I believe, that was trying to look at the diagnostic yield of biopsies as well. And so this study was very interesting. They again looked retrospectively, single center study, but this was for all their patients over the course of about 10 years who were admitted with fulminant myocarditis in their intensive care unit. They put them through endomyocardial biopsies, and you can sort of see how the biopsies affected their management. So looking at the first column there, definite myocarditis. So in 55% of the cases, they got biopsies that were confirmatory for myocarditis and gave them the diagnosis of myocarditis, which I think was probably suspected based on their clinical judgment. But if you look in the second bar there was 32% of their biopsy results that actually led to an alternative diagnosis. And then sort of looking down further in the chart, 32% actually had treatment modification based on their endomyocardial biopsy. So there is definitely some variability in endomyocardial biopsies, but it is a very useful tool. It can be very diagnostic, and it can definitely help you to treat your patients better. So I think that there's some strong evidence here between those two studies to sort of suggest that there's a utility in these different disease states for for doing myocardial biopsies for these patients. This just goes back to the point about using diagnostic imaging before you put someone through an endomyocardial biopsy. So if you look at these two images here on the right side of the slide, the first one, this panel A, is a patient who had acute myocarditis. And if you look at the little arrow here, the little white arrow down in sort of the inferolateral portion of the myocardium, you see that there's some sort of white highlighting in the myocardium. And this is an area of the myocardium that was affected by the myocarditis. But if you sort of look at the rest of the myocardium, and specifically the interventricular septum between the LV and the RV, you don't really see that same white highlighting in that part of the septum, in that part of the myocardium. And so this is really important, because if you were to try to biopsy this person, you are going to try to obtain the samples from the interventricular septum, presumably from the right side of the interventricular septum. And there's a high likelihood that your samples are not going to show you your diagnosis. They're not going to have a high yield, because of the fact that, in this case, the myocarditis is really only affecting a portion of the myocardium, not the entire thing, and specifically not the interventricular septum where you're going to obtain your samples. This is in comparison to the image on the right, which is a patient who had cardiac amyloidosis. And you can see that the entire left ventricular myocardium, including the interventricular septum, highlights with that sort of whitish pattern there, suggesting that the entire myocardium is filled with amyloidosis. And so really, no matter where you biopsy in this myocardium, whether you go from the right ventricle and obtain septal pieces from the right ventricular side, or you come from the left ventricular side, I think your chances of obtaining a sample that has amyloidosis and confirming your diagnosis is going to be very, very high, because of that diffuse nature of the amyloid process. So this is just a way that these imaging sort of complement our biopsy procedure. So as useful and as helpful as endomyocardial biopsies are, it's always good to know when to sort of stay away. And so there's some patients where a biopsy would be contraindicated, and it's always good to know about these. So if someone has an intracardiac thrombus, specifically within the ventricle that you are planning to biopsy from, it's always a good idea to stay away, because of the chance of disrupting that thrombus and causing an embolism somewhere. If they have a ventricular aneurysm where the myocardium is very thin-walled, you may want to stay away because of a high risk of perforation. Anyone that has sort of severe tricuspid stenosis, pulmonary stenosis, aortic stenosis, these sometimes just lead to difficulties passing the bioptomes and passing the equipment through them. And so you may want to stay away because you may end up causing some damage while you're trying to obtain your samples. And then lastly, people with mechanical prosthetics. Again, if you're going on that side, so if you're trying to do an LV endomyocardial biopsy, but someone has an aortic mechanical valve, you really should not be passing any equipment through there, and that would be a contraindication. And then there's some other relative contraindications, and that very well may play into just your comfort level. And so someone who's actively bleeding, again, probably going to want to stay away. But if the diagnosis is really essential, you may sort of just look at that as a relative contraindication, not an absolute. Same thing with people with infections, fevers. If you think that your infection and fever is related to your underlying process that's causing your heart failure, your myocarditis, then that may sort of be a relative contraindication. Again, people who are pregnant, you probably don't want to be exposing them to fluoroscopy to perform your procedure. But if it's going to lead to your diagnosis, if it's going to help you manage the patient better, you may proceed with the biopsy anyway. And then again, other things like thin ventricular walls, uncontrolled hypertension, coagulopathy, uncooperative patients, all just little things to keep in mind when you're thinking about performing a biopsy on a patient. And unfortunately, as safe as I like to think this procedure is, there's some risk of complications with this procedure. In general, the risk is somewhere between 1% to 4%, depending on what literature you look at. In this article here from JACC Heart Failure back in 2022, they quoted a complication rate of about 4%. So, some relatively low risk of complications, but not insignificant. And, when you sort of break down what the complications are, the number one most common complication is a pericardial effusion, presumably from, perforation while you're performing the endomyocardial biopsy. Other sort of common or prominent complications are some vascular complication, presumably from your access site, and then maybe some sustained or non-sustained VT, a pneumothorax related to the access site, and then a small subset of like tricuspid injury, temporary AV block, things like that. So not insignificant risk of complication, but not a prohibitive risk of complications. And definitely, I think the more that you do these procedures, the lower your complication rates will go and the safer you can perform them. And then just sort of thinking about where this field is going, where the procedure of endomyocardial biopsy is going. Again, in this top right corner here, I sort of mentioned this earlier, that there is some role for LV endomyocardial biopsies. In general, I think people tend to stay away from this because the risk of a complication on the left ventricular side probably a little bit higher, at least the seriousness of those complications. So if you have a perforation on the left ventricular side where the pressures are higher, this can become a rapidly critical situation with pericardial effusions and cardiac tamponade. But I do think that there is an important role for this, kind of thinking about that MRI that I showed before, where the myocarditis was sort of isolated to the left ventricular inferolateral wall, and if you really need to make a diagnosis, then you sort of would be forced to do the LV endomyocardial biopsy. Imaging guided endomyocardial biopsy is also another area where this field is growing, again, for diseases like sarcoidosis, where the disease may sort of be kind of focal within the myocardium, and you really want to sort of pinpoint where you're obtaining your endomyocardial specimens from. Having some imaging to sort of guide you and increase your yield for that biopsy is really very useful. And I think that this will be a modality that we use with more frequency in the future. Intracardiac masses, again, another sort of interesting utility for this procedure. Right now, I think the gold standard is still to sort of perform a open surgical procedure to get your tissue diagnosis and figure out how best to treat the patient. But I do think that there are certain scenarios where a percutaneous approach to obtaining tissue directly from the heart is very useful. And actually, this image here that I show you is a case that we had here at my institution, where you see this mass in the interatrial septum. And very interestingly, it was a giant sarcoid granuloma. And so we were able to get very good tissue samples. We were able to start the patient on immunosuppression for their sarcoidosis. And within a few months, actually, this mass dissolved or resolved. And so we avoided an open heart surgery. We avoided a surgical procedure, and we got the patient treated in a pretty minimally invasive approach. So that was a very exciting case for us, and the patient had a very good outcome. And then lastly, here on the bottom right are improved techniques and equipment. I think this is where Argonne really, we have a great partnership with them, and they're really trying to push the field by innovating in their equipment and innovating in the approaches and ways that we obtain these endomyocardial biopsies. And so if you compare, our current equipment to equipment that we had 10 or 20 years ago, I think the equipment now is much safer. It's much more sort of quote unquote user friendly. And I think, there's probably still some room to improve the equipment. So this is always exciting too, to be involved in those next iterations of our bioptomes and our equipment. So, that pretty much concludes, this part of the talk. Again, I think it's a very useful tool. I think you need to think about it in select cases and which are the appropriate cases. But, the societies definitely support the use of endomyocardial biopsy. There are guidelines to guide us, and imaging definitely complements these biopsies. So always think about imaging before performing your biopsy procedure.
Excellent. Thank you so much, Dr. DiVita. We appreciate it. And just as a reminder, everyone, once again, if you have any questions, please put them in the Q&A or in the chat, and we'll make sure that we try to address them before the end of the evening. And now, without further ado, it's my pleasure to introduce you to Dr. Tony Saroan. Dr. Saroan is an advanced heart failure cardiologist at NYU Langone. His clinical focus includes the management of cardiomyopathies end-stage heart failure, and mechanical circulatory support, including LVADs and transplant evaluation. Dr. Saroan integrates advanced diagnostics such as cardiac imaging and genomic profiling with multidisciplinary care models that deliver highly personalized treatment. His team emphasizes both clinical outcomes and quality of life, addressing the full spectrum of needs for patients living with complex heart failure. Dr. Saroan, please take it away.
Great, thank you very much. I really appreciate this opportunity. I'm going to review something that we came across with our high volumes, which is a different approach, which is really getting in with the arm, the brachial experience. So those are my disclosures, and we're going to talk about access. Does access matter? From the point of the patient, it matters a lot. From the point of the proceduralist, it also matters a lot because they want to deliver a safe procedure. So trying to find that in between where we can do the safest, but also the least painful and least harmful thing for the patient is kind of where we got to our brachial procedures. We'll give you some results from the published literature, what the patient experiences have been at our center and how important that is to us, some of our internal data, and just review the technique that we do now about 80% of our biopsies. Just to give you a number, we're doing between 500 and 700 biopsies a year, each year for the last 5 years. So, you know, our team and honestly, Mike mostly now does these biopsies. And we found that having every tool at your armamentarium, be able to access from different sites and really obtain what's needed for that patient and do it safely and quickly is really the best approach to biopsy. Next slide. So, you know, the endomyocardial bite, you know, it's just a short picture to show you how small it is. It's really a tiny look inside the heart where we sample a piece. And when I first started to learn biopsy, I was like, how could you perforate someone? It seems so difficult and this device seems so safe, but any of the thin walls in the areas of the heart that you shouldn't be, like the RV free wall or the atrium or these areas, it can perforate. And then really getting to the right spot and really grabbing that piece is not very injurious, doesn't create much injury, but you just have to be careful. And looking at this biotome on the inside of it, you can see this is about a 2 to 3 millimeter piece, which ends up being very good for diagnosis. And ideally, you want to move along the different parts of the septum. And if you look at this top right picture, you can see that tricuspid valve apparatus. Now, grabbing onto any one of those structures will lead to severe TR. So being mindful and being able to avoid all that, we'll talk about how our brachial technique actually protects it. It's tricuspid valve sparing is part of its advantage. So, you know, Mike had reviewed this, but why do we need to do endomyocardial biopsies? It's for the myocarditis, it's for the transplants. I'll tell you the blood testing has been an excellent addition, but there are false positives. So the test comes back positive and that triggers a biopsy. So we still end up having biopsies we have to do. When it's negative, it's great. We can skip biopsies for transplant now, but when it's positive, we just don't know. So we actually will do a biopsy, not just treat the patient. And this world of amyloid is really expanding. You get crossover diseases. We see it on the side of transplant. You know, the patient's going for a transplant and we're sure it's amyloid or sarcoid or HCM. We get the heart explanted and the pathologist is like, oh, that was not sarcoid at all. It was HCM or it was something else. So we're learning that even though imaging is great, without tissue, sometimes we can be incorrect in our diagnosis. And in crossover diseases, like someone who has multiple myeloma or high kappa lambda ratios, and then they also have a TTR gene. So do they have AL amyloid in the heart? Do they have TTR? So that triggers biopsies as well. And some of the newer treatments, they want tissue diagnosis. So in the studies, which we're involved in for amyloid, they require tissue diagnosis to even enter some of these studies. So it's becoming a more prevalent tool. And again, the tumor disease and the unexplained heart failure with this mixed picture is where we're seeing a growth in our program. So just to review the traditional access, I was trained on jugular. I was trained with this device that you can see that looks like a scissor. It's called a Scholten biotome. It's a great biotome, but it's one of the older style ones that's difficult to use, difficult to learn. It requires a lot of prep work to curve the biotome and find the right shape, but it works. And when you access the jugular, it's a nice direct access, but it's a little less comfortable for patients right in the neck, especially when it's people who've had multiple biopsies and they've had internal jugular access for lines, whether it's swans or central lines, and then you're going back in the same area. It's visible, like a visible scar that patients will mention. They'll overcome it, but there are things that bother them. Also, when I was taught in doing these biopsies, you're standing right underneath the eye, so the radiation is right on you. I was also shown how to kind of bring the shield in front and kind of wiggle your arms under, but it's inconsistent. Sometimes you have to really get under there if you can't get a comfortable biopsy. Femoral is very familiar. You know, a lot of the interventional folks are trained on that, and you know, very familiar, very easy approach. But for the patient, it's uncomfortable. They'll lay flat for a couple of hours. It's, you know, bruising, and you know, they kind of remember it for a few days. So it's a lot different experience for the patient. So it limits their mobility, which I think is one of the bigger things that patients complain about. Next slide. So what are the advantages of coming from the arm? And when I talk about brachial, I'm talking between the elbow and the armpit, right? It's like a PICC line access. So we avoid the neck, we avoid the groin. They can immediately ambulate post-procedure. There's a lower vascular complication risk. There's a high patient satisfaction. And it's really ideal for an outpatient program and a really high volume program. Most of my patients are 45 minutes and they're leaving. And the only thing that might keep them is if for some reason they wanted some sedation. I have one patient who comes from upstate and wants to drive home. It's no problem. We don't give any sedation. We do brachial biopsy and he drives home. So it's been a very effective tool for a subset of our patients. And then we've moved now to about 70 or 80% of our biopsies being from the brachial approach. So we look at the literature. There's not that much publication on brachial. There's maybe 2 papers out there. One of these papers is over 12 years. It's from Tamargo's group. Excuse me. They approached the brachial biopsy without ultrasound. They were doing it with feel, and they were getting access with IV, and we're getting a 94% success on their access. And we're doing biopsies from the brachial. I'll review their technique quickly and then kind of go on to ours, and just kind of explain the things I learned from their paper and how we adapted ours and made it a little bit better. And what they found doing about 50 biopsies a year was they had 1.6% minor complications, 0 major in their study. It was a retrospective review, and they reported these kind of like 48-hour outcomes. Go on to the next slide. And when you look at the literature by access route, you know, brachials really got close to 0. When we look at our center, I'll show you our data as well. Jugular is around 0 to 0.8, depending on the paper, and femoral is about, you know, 0.1 to 0.6. And then if you add in the minors, and that's what Mike was showing, you kind of get to this around 4% complication rate. You know, in this Tamargo paper, they also compared a lot of their data. So if you look at the procedural times, the brachial, the femoral, the jugular, they're all pretty much the same. They're taking them just under 30 minutes to do the full procedure. If they add in things like, you know, right heart cath with a full study or angiography with a full study, the times go up a little bit. And that's what creates a variation. And the fluoroscopy times, the jugular is the least, and I would say it's similar at our center. The brachial and femoral are close tie. They're looking at about 4 to 5 minutes. And of course, they're a little bit higher when they go to these, you know, right heart caths or they add in angiography. And what about the pain scores? So they did look at the retrospective kind of pain score. So they asked the patients, wasn't that many. I think it was around 25 or 30 patients that they ended up asking. But, you know, 2 out of 10 was brachial and 8 to 9 out of 10 was femoral and jugular. This is what patients remembered. We get through the procedures, we give sedation, but this is what patients remembered after their experience. And the spectrum here was almost nobody was more than a 5 out of 10 on the pain from the brachial, and nobody was less than a 5 when you went jugular or femoral. So just a very generally painful experience from what patients recollect, which is interesting because we try our best to sedate and give, you know, a lot of local and make it as comfortable as we can. But from the patient side of things, they really, you know, they score it really high from a pain score. Next slide. So what about our data? So we're going to be publishing this data shortly, but this is over a period of 3 years. Jugular, we did about 600 in this retrospective review. Femoral, about 181. Brachial, 848. The procedural time on the jugular and the brachial was about the same. It was slightly better on the brachial, but the femoral was a little bit longer for us. The fluoro times are also better in brachial, and I'll explain why. Our technique kind of evolved, so we didn't need so much fluoro anymore. And then the complication rates between jugular and jugular and brachial are pretty similar, but femoral had the most, mainly driven by the minor complications like hematoma, bruising, pain, and things at the site. And then when we actually looked at our technique prospectively, only brachial for another 300 procedures, and we found it again is about 29.6 minutes on procedural time. The fluoro time got even better at about 4 minutes, and again, zero major, and about 3% in 24 hours. And then we call patients up to a week later, and they again, even though they had nothing at the 24-hour, at 5 days to 7 days, they had reported some hematomas and things that we may not have captured if we didn't call them back. So it was more about 10%. Nothing that drove them back to the hospital or anything, but just something they mentioned to us. So that helps us learn and be mindful about our procedure. Next slide. And what do patients prefer and what are their anxiety levels? So, out of 273 patients who we were able to speak to, they said, we prefer the brachial over everything else. We said, you've had brachial, you've had jugular, you've had femoral. Do you have a preference? Which way would you go? 90% said brachial. Brachial is the most preferred approach for everyone. And the reason they cited was mostly less pain, shorter recovery. And then it was a whole bunch of other things that were 270, meaning 90% of the time, that they preferred the brachial approach, but there were things we weren't even anticipating. Things like my leg didn't hurt, and that, even though my arm did, I just don't want my leg to hurt. So, it was interesting that they were comparing to their other experiences and really talking about why they preferred it. Was a bunch of things we don't anticipate, but is important to the patient. So let me just review quickly how we do our technique. And first we'll talk about the Tomargo paper and how they do theirs and how we kind of adapted ours. So brachial vein anatomy, it's the Mickey Mouse ears. You're going to have this bundle, the nerve on top. So this is in the yellow circle. Really faint, you can see it above the Mickey Mouse head is a faint brachial nerve. Then you have two veins, one on each side. Those are the ears. And then the head in the middle is the artery. So you can approach these veins. These veins are the brachial veins with the bundle, but clearly they're right next to the nerve and right next to the artery. So, it requires some learning, some experience. But look here to the right. There's the basilic vein. And if you come up and you trace up with an ultrasound, this will tie into your brachial vein. So that's the vein we typically choose. It's right before the brachial veins, and it's away from all those structures. It's usually a little bigger. It's accessible. It can handle a 7 or even 8 French sheath if you wanted it. We use 6, but this is a kind of vein, and you can access it repeatedly. You can move up and down for previous access. The scar or the marking is on the inside of the arm, so the patient doesn't really see it. And so that's kind of our preferred approach on this vein. And this is just kind of a color marking. So the Tomargo group this is their pictures from their study. They used a 7 French sheath. They used something like a guideline catheter. So after they got their 7 French sheath in, which is in the B or the right top square, they then added this guideline catheter, which you can see it sticking out from a long sheath that they placed. But then the sheath was too long, so they have to cut it with a scissor. So you see them cutting it here. But then there's no valve and there's bleed back. So then they had to add another sheath. So they had a lot of these kind of ways of what I call MacGyvering it to make it work. It worked, but it required all these steps. And in the end, they had this kind of, it's kind of faint here, but you can see the catheter coming down from above and approaching and facing towards the spine. And that's really leading you up to the valve. Again, they're not always past the valve. And I'll show you how we do ours, which actually spares the valve. So this is our equipment. I know there's a lot of crisscross lines. I had some animations, but unfortunately I couldn't use those. But if you look at the very top going across is something called an Ansel curved sheath. This is a 6 French 55 centimeter 55 or 70 centimeter sheath. We then have a swan we use. We have a J wire that goes with that. We use a 6 French access sheath. And then we use the argon Jawz. They're the only company that has the 70 centimeter 6 French biotome. It works really well with the 55 long sheath. So that pairing has been one of the key benefits of using this their device and this technique together. And this equipment works perfectly. So here's my setup for the brachia approach. You'll see some scar marks on the arm here. This patient's been through 4 or 5 biopsies before, and they're all on the inside of the arm here. The veins stay patent. You can come right back in again. So I stand by the head of the patient and I get my access with ultrasound. And, you know, on the left, you can see this patient's anatomy. There's a artery in the middle. It's a little bit different. He's got 2 veins on one side, 1 vein on the other. And the nerve for him is down below. So I always think this is interesting. So 65% of the time you get typical anatomy, 35% you get different anatomy. So you just have to adapt. And then again is the basilic vein off to the right, which is what we access. Go ahead, next slide. And here I've already got the sheath in. What I do here is I take a J wire and I exchange for this Ansel sheath. So there is no sheath in the arm other than this sheath. The advantage of this sheath is it has a sticky coating. So when you go through the vessel, there's no bleed back. And it's the same size as a 6 French short sheath where you get your access. You can just go with this sheath all the way into the apex of the heart. And it has a curve to it, which nicely puts you in the septum. And if you look at the top area here, I have a shield. So again, from the jugular, no shield, right? And I can put a shield right down in between. It does not affect my procedure because my sheath is there. And you'll see that advantage in a second. And there's a rad pad to the right. So you're really minimizing the radiation to the physician performing the procedure. And this is really important to me and to our team because we do so many of these biopsies. We want to minimize some of this exposure to the whole team. So here I take that J wire and you can see it's all the way down into the right atrium. And I push along that sheath to about the SVC junction. So it's got a little intro in there, and it's got, you can see that tapering down, the J wire, and the sheath with the bright tip there. And so that's really helpful to kind of give you a marking point. Then on the right side, I take that swan catheter, that's 5 or 6 French, and we push it through. And if we want to do a right heart at this moment, we'll do the right heart. But you can see it's in the RV kind of facing up towards the PA. And you can rail it and push your sheath all the way up to the balloon. You'll never perforate because you have a balloon up. And the balloon will give you about a 1 centimeter distance from the septum. So as long as your balloon's in the right place, you can put your sheath right behind it. And when you drop your balloon and pull your swan out, you get a little bit of distance between your sheath and the septal wall. Next slide. And here you can see that sheath, and compared to that Tamargo paper where it was before the spine, ours is way past the spine. So I'm past the tricuspid valve. I'm in a position where I'm secured. I'm facing the septum. I look at LAO to really make sure that the sheath is not facing the RV. I have used that balloon to know where the RV is. So look at the distance it gives me to the RV and the different areas I can sample for biopsy. And we go open with the argon Jawz here. We take a bite and we come out. And while I'm navigating all the way in and out of the sheath, I don't need fluoro. So the advantage here is that the sheath is 55, the biotome is 70. And so with experience, you can go in almost 90% of the way, and then you don't have to hit fluoro until you're at the end point. So therefore, you save all that fluoro for the patient, you save that fluoro for yourself, and you can come out, just take your bite and get out. And you could do 1, 2, 3, get your final pressures, and you come out with the sheath, just drag it out. It's not like the artery side where there's atherosclerosis and things you worry about. You can just pull the sheath right out. So the biotome's already out, we got our pieces, and then the sheath comes out in the end. So it's a really fast and cute technique. Next slide. There is some limitations here you have to consider. There is some learning curve for the access. The way I learned the access was to go to our PICC line team. I was watching them from the door one day, and I was seeing how quickly they'll get it at the bedside with just ultrasound. And I just went and asked them, what are you guys doing that's different? And they were able to teach me, after a few patients, a bunch of tips and tricks. Normally we're used to an arteries coming in at a high angle, 45 degrees. They go in like they get IV access. They're right up against the skin, really shallow. You get a great approach to the vessel that way. They also understand the anatomical variations, and we use exclusively ultrasound and fluoroscopy to get this access. So those are some of the limitations and things to consider. And we add ultrasound. So I'll tell you what's interesting is if the anatomy is distorted, it's a really dilated heart, really thick heart, congenital, LVH, RVH, and amyloid, your position may on fluoro may not actually be where you think you are. So adding in that bedside ultrasound is really effective. Challenge is I don't have a tech. So what I'll do is put that sheath in where I think is facing the septum, and it just sits there, and I can, scrub out, walk around, or if I have my prep done properly, I can ultrasound and just leave the sheath there, because I know when the biotome comes out, it's going to follow the same path. So as long as my sheath is facing septum and I'm happy with it, I can leave it, take a look under ultrasound. Oh yeah, I'm definitely on septum. Go in, take a piece, and come out. It's not that often we need ultrasound, but there's times now when I look, I'm like, ooh, I'm not sure exactly where I am. And that has really helped me avoid some of these patients' complications and really make sure I'm getting samples that are in the deep septum, meaning towards the apex. Then I can pull the sheath back a little bit and kind of creep up towards the mid septum and get different areas and different pieces to improve our yield. Next slide. So, it's a safe, efficient, it's a patient-centered approach. It's definitely something to add to the skill set, because I think there's patients you can't do brachial. I've had patients come down from the floor and they have a PICC line. So you have to do jugular, you have to do femoral, other approaches, but it's a good viable alternative. And in a large volume centers where a lot of outpatients exist and they have access there, they really prefer it, and we have gotten good at it, and we prefer it. We can turn over the rooms quickly. We can get patients discharged quickly. And, considering like a pilot implementation at different centers is the way to go. And just gaining that experience and getting better at it. It's the same as what we did with like radial approach. Once we saw the patients liked it and that we got comfortable with it, we moved ahead and went to a high level. And I think this is going to end up moving in a similar direction like it has for our program. Again, 70-80% our biopsies are going brachial now. But that's the end of my slides, and open to any questions or any thoughts.
Well, thank you to you both. I mean, that was a fantastic presentation. And we do have a couple questions, if you don't mind me sharing. And I'm just going to throw this out there. You guys, any one of you can pick it up. But one of the first questions that we have that kind of came up in our chalk is that, in your experience, what are the most common reasons for non-diagnostic samples, and how do you generally mitigate them?
Yeah, I mean, I think I can take the question. I think there's a couple of reasons. One is, again, like we talked about, processes that are not diffused throughout the myocardium. That definitely leads to, inefficient sampling, inefficient yield on your biopsies. But I think also, to Tony's point, like understanding the technique, really understanding your anatomy, knowing exactly where you are. We do unfortunately see times where, the pathologist will call us and say like, hey, listen, I have a piece of the tricuspid valve here, and the operator thought they were getting good samples of myocardium, and they're either sampling cords or they're sampling the valve, or, maybe they're, I don't know, really towards the apex, and, they just get tissue that's not appropriate and not adequate. So I think, understanding your anatomy, understanding when, you have a difficult patient with difficult anatomy, and some of the tips and tricks that you can use to really ensure that you're sampling pieces from areas where you mean to be sampling and want to be sampling. One thing that Tony sort of alluded to, but, that I also use sometimes as well is, if I'm not sure about the anatomy, I'll take wires or I'll take the Swan catheter and put it through the sheath and sort of, either put the Swan all the way up into the PA to sort of give myself a roadmap of what is the RV and what does the RV outflow tract look like, and what is sort of the anatomy of that structure look like, that cavity, or take the J-wire and sort of put it into the apex so I understand exactly where the apex is. And so I know sort of where to stay away from, or just to sort of orient me a little bit more, because sometimes it's not very clear. And so I think understanding that anatomy will yield to higher yield on your biopsy samples.
And I'll just add something. I'll tell you, in the first couple years as we grew our volumes, I did have a few of these. And honestly, now I have none. And the difference has been that the pathologist would call us up and say, hey, no samples that were adequate. And I would just go over and say, what do you, and he thought I was mad or something. I mean, no, I want you to teach me, what am I looking at? So I would look at the samples, and that now, even I think Mike does this too, right? Tell me, we take the samples and we look at them in a bowl, and we can look and see that this is an adequate sample, because we were able to go back with the pathologist and compare. It's nice and red. It has all the right contours and shapes and things we're looking for. And if it doesn't, you just keep going. You reposition. You realize that this patient's here for their biopsy. They need to get a diagnosis. I don't want to bring them back. And, we're going to take an extra minute or two and really understand, I did everything right, but there's something different about this anatomy that we might be missing. And the other thing I would say is that in conditions like sarcoid and even amyloid, where you may not be in a place where it is, so the sarcoid might be in a different position, and again, using that ultrasound and really understanding, well, where is the disease on the MRI, the ultrasound, so that I target the right spot. I've had some people come to me, say, do a biopsy on this patient, and I'll look at the ultrasound. This is all areas I cannot get to. And so I just refuse to do it. So I said, you're not going to have that yield. And I think, Mike, you had that experience too.
Yeah, absolutely. The other thing that I will add to this sort of conversation is that, especially for the transplant patients who get repeated biopsies, and some of them get many, many biopsies, some of them unfortunately suffer from rejection and sort of need constant biopsies for surveillance. Again, looking at those samples, making sure they look like appropriate myocardial tissue. And if they don't, one of the things that I really like about the argon products and the bioptomes is that they are shapeable, most of them. And so, if you look and you see that, sort of the way that your equipment is directing you is not getting you a sample that looks adequate, the ability to sort of make different shapes on them, give more curves, go a little bit higher up on the septum, sometimes a little bit lower on the septum if, that's where you think you can get an adequate tissue sample safely. And just having that ability to change, where you're directing your equipment to try to get a better sample has really helped me out.
So you mentioned approach. I think it's kind of important to address, because you have converted 80% over to that brachial for the many reasons you stated, from the ease of the access approach, reducing radiation exposure to yourself, but that still leaves 20%. So what exactly normally is that variable? Why do you say, okay, what are those parameters that would prevent us from doing those patients and getting either, a brachial versus having to go jugular femoral when you normally have to convert?
So I think, go ahead, Mike.
So for me, I have two reasons. One, you stated before, Tony, which is sometimes they just have other equipment, especially our transplant patients. Some of them, the fresh transplants, they're coming down with central lines, PICC lines, chest tubes, and A lines, and a lot of stuff that sort of gets in our way, and we have to think about alternative approaches. For me, also specifically again to the heart transplant patients, some of our procedures that we do on them involve another procedure, for instance, like a left heart cath, if we want to look at the arteries of their new heart. And so trying to do both of those from like a radial approach and a brachial approach for the biopsy becomes a little cumbersome. We sort of want the arm positioned a little bit differently for the two different approaches, where in the brachial approach, we usually have the arm really all the way extended out, almost at like 90 degrees, but that's not really good position for a radial approach. And so if I have to also do a left heart cath at the same time from the radial access, I usually like the arm to be tucked in a little bit closer. So in those instances, I'll usually tend to do the arteries, the left heart cath from the radial, and then do my biopsy from the right internal jugular vein. So that probably lends to a significant number of our biopsies that are not done from the brachial just for that reason alone.
Breast transplant, easier access.
Yeah, and I'll just add, like, and I think, Mike, you think the same way. When it's a straightforward biopsy, the first thing I think is, can this be done brachial?
Yep.
And that's the approach. And if it can't, then we switch over. And like you mentioned, there may be lines, they had a PICC line and now the vessel's clotted. Sometimes they had a pacemaker on that same side, the right side where we're approaching, or an ICD, and there's leads there and you can't get through. So there may be structural reasons you can't get through, but we just always think, can you go brachial? No? Okay, now we go somewhere else. But it's always our first thought. And it's really become that way because that's what the patients want. And to the point that I was doing the majority of brachial and my group was not. And I would exclude Mike from that because Mike got on that right away. And the patient would just say, no, I'm not doing this unless you go brachial. Yeah. Or where's Tony? Why is Tony not doing this? And so, it would create this kind of pain for everybody else. But in a way it worked because now everyone does it. And it creates an opportunity.
Cardiology specifically would adapt to that because that's the whole transradial argument, right? Why do patients like transradial? Why do we like approaching it? Right. So it kind of is in alignment with that argument. I guess I got one more question for you, and then we're going to call it an evening. I'm going to have you guys look in your tea leaves and pull out your crystal ball. And if I like the answer, we're going to go to Vegas because we might be lucky here. But when we look at biopsies, similar to what we've seen in the peripheral world biopsies, years ago, we thought liquid biopsy would supplant it and we'd find good molecular biopsies that would really kind of limit the amount of biopsies we had to perform. But when genomic testing came in, when some of these newer types of immunotherapies came in, it became the opposite. We kind of were getting the pushback of we need better tissue, we need more tissue, we need definitive lines and less crush artifact. If you guys had to predict, looking at heart failure, looking at all the parameters and disease states, especially with COVID and these weird inflammatory states that we never historically saw, in as many patients that we saw recently in recent memory. Do you guys think that biopsy may become more a utilized tool, or do you think it'll be less? What's your thoughts? Because I'll tell you, in general biopsy for years, I thought we would end up reducing it less and less and less. And what I'm finding in practice is it's the opposite with these newer medications and these newer protocols. We need better tissue to be able to get the genetic profile, be able to treat these patients.
I think it's going to grow in these other areas. Like we already see it in the amyloid trials. Like if you want that genetic modifying therapy, which is a gene modifying therapy and brings your genes that are mutated for amyloid back to normal, it's an expensive treatment and they want to be sure you need to have a biopsy. They want the gold standard. So I think what you're mentioning and what you're saying is there's these niche diseases and processes that require that. I do think we're trying to supplant it with imaging. So, non-invasive is still in my mind the way to go. I don't enjoy the biopsy experience. I'm always trying to make it better for the patient. But I think because these diseases are so specific, or we want to catch them earlier, you catch them in the tissue. So I think we're going to get this shift towards trying to diagnose earlier, but then you confirm with biopsy. And then you get into that expensive or somewhat risky or not risky type of treatments. What do you think, Mike?
Yeah, I agree. I think that there's going to be actually increased utilization of the biopsy procedure for things like you said. There needs to be more exact diagnoses for certain conditions, certain research trials that are coming out. I mean, you and I have already sort of talked about this. Even things like some of the dilated cardiomyopathy trials that people have approached us for, the hypertrophic cardiomyopathy trials that people have approached us for. Like, if there's ever a question about what the actual diagnosis is, before you start these patients on these really expensive medication regimens and novel medications, you want to know exactly what you're dealing with and make sure that there's not, a conflicting etiology, an alternative etiology that, was sort of underthought about or under-recognized. So I see that the field is growing. And even though in the transplant world, there may be new tests coming out to sort of reduce the number of biopsies that patients are getting, I think in the grand scheme of things, we're probably looking at an increase across, all the different disease states.
Well, I want to thank you. Oh, absolutely.
The amyloid world is very interesting, right? We diagnose it based on imaging when there's this significant infiltration in the heart. And so we have these patients in front of us and we start to treat them and they already have it infiltrated in their heart, right? And then their children come and they also have the gene mutation. Am I going to get this disease? Well, it turns out it's about 10% chance of expression. But do you really want to wait until they have a imaging positive amyloid throughout their heart? I mean, it'd be nice to catch them earlier. So I foresee catching earlier patients, diseases, patients who are gene positive, but we don't see it on imaging, getting tissue for those patients. Like, as long as we keep the risks low and the benefits high, I think that's going to be another area. Because catching disease earlier is the key to treatment.
No, absolutely. Yeah, it's always, the sooner we can treat these patients, the sooner we get them in the care algorithm profile, the better we know the outcomes are going to be. So before we close, I want to take a moment to sincerely thank everybody for joining us this evening. We're grateful for your time, your engagement, and your commitment to advancing clinical knowledge in cardiovascular care. We especially appreciate your patience. Once again, apologize for the delay, and thank you for sticking with us. A very special thank you to our esteemed panelists, Dr. Tony Saroan and Dr. Michael DiVita, for sharing their expertise, perspectives, and thoughtful discussion around the role of endomyocardial biopsy in transplant and heart failure management. Your insights tonight have added real depth to the conversation, and we're honored to have you guys with us. And we hope tonight's session sparked new ideas, validated your clinical instincts for some of you, and perhaps even challenged your current thinking on some of the ways to do these endomyocardial biopsies. Please keep an eye out for our next ACES virtual event, which is already in the works. And until then, thank you once again for being a part of our community. Have a good evening. Appreciate you, everybody.
Great. Thank you.
Thank you, guys.